Hi, everyone, and welcome to the virtual health series with UC Health. My name is Hannah Parrott, and I'm an event coordinator with the Highlands Ranch Community Association. We are so excited that you all took the time out of your evening to join us tonight to discuss the very important issue of genetics and the risk of breast cancer. We are grateful for UC Health Highlands Ranch Hospital as a community partner and happy to host this wonderful event with their assistance. Before we get started, I would like to go over a few housekeeping items. During this webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box. This can be found in the control panel, typically on the bottom of your screen. We will save the questions for the Q&A portion towards the end of this event. Our presenters this evening are Kristina Markey and Dr. Jodi Widner from UC Health. Now, without further ado, I will pass the time off to Dr. Widner. Dr. Widner, we are having an issue hearing you and seeing your video.
There we go. Okay, can you hear me now?
Oh. Yes, yes,
okay,
we can hear you.
There we go. Once you started sharing, I couldn't unmute. So now I should be all set. All right, are we good now? So again, I'm Dr. Jodi Widner. I apologize for the delay. I'm here to talk this evening about updates in breast cancer screening and treatment. I'm the director of the breast center at Highlands Ranch Hospital. And again, I'm kind of the opening act. I know we had listed this as a talk about genetics, but I'm going to start by just giving you some updates in the most recent breast cancer screenings. So current American Cancer Society guidelines, our recommendations are for women over the age of 40 to receive yearly mammograms, a yearly clinical exam, and oftentimes to do sort of a monthly self-check. We have really gotten away from the rigorous self-breast exam. Most women had a lot of difficulty with this. They really struggle. And so really what we recommend now is that you know your breasts, that you are familiar with what's normal for you and what's not. But doing that minute exam once a month was oftentimes more aggravating than it was helpful. So we encourage women just to be aware. Women between the ages of 20 and 39, we do recommend that you get an annual breast exam, get a breast exam every 3 years, as well as, again, just kind of be aware. A lot of people have heard about the guidelines that came out in 2015 from the U.S. Preventative Task Force that recommended that mammograms be pushed back to age 50. and that mammograms should be only every other year. Current breast surgeons, the American Society of Breast Surgeons, the American College of Radiologists, all recommend that these recommendations are not enough for most women. We really encourage women to start their mammograms at age 40. I also encourage women to continue screening after age 75 if you are healthy. My rule of thumb is if you can get yourself to the mammography center, you should get a mammogram. There's a bit of a delay, I apologize. There we go. High risk screening. Women should include yearly mammography, yearly MRI, and a clinical exam every 6 to 12 months. High risk, we're going to talk about a little bit further, and Kristina Markey is especially going to discuss this in more detail. For a lot of women, this is high risk is if you have one of the genetic predispositions, but also if you have a family history of breast cancer, you should be aware of this. Our recommendation is you should start screening 10 years younger than your youngest relative. So if you have an aunt who developed breast cancer at age 40, you should begin screening at age 30. Again, who is high risk? We're going to talk a lot more about that in a moment, but really it's people with a known genetic predisposition or first-degree relatives, women who have a lifetime risk of breast cancer over 20%. Most women, when you come in for your mammography, they will, the mammography center will ask you a variety of questions, and those are designed to calculate a risk score. If your risk is greater than 20%, you're considered high risk and qualify for more advanced screening. Also, one of the common problems that some women develop after radiation is breast cancer. So it's very important if you have had chest wall radiation for any reason, especially between the ages of 10 and 30, for things such as lymphoma or Hodgkin's disease, those screening tests need to begin 8 years after radiation ends, because that is a very strong risk factor for development of breast cancer. 3D mammography is one of our screening tools that's relatively new. Some people will hear this called tomosynthesis. This is a specialized mammogram that has become very common very quickly over the last 5 years or so. This mammogram is the same dose of radiation as a mammogram, but it gives the radiologist a much bigger picture because it takes multiple slices through the tissue. It's almost like a CT scan of the breast. For most women, as they have this 3D mammogram, they don't recognize the difference between their standard mammogram, but there's many more images for the radiologist to look at. This can help differentiate a true mass from just dense tissue that's lying next to another piece of dense tissue. For most women, what this does is it allows us to avoid callbacks, meaning that you don't get called back for a diagnostic. Useful also for women who have dense breast tissue. This used to cost a little bit more, and at times still does, depending on your insurance coverage and the facility. But for most women, this has become really the standard of care, and most facilities, there is no additional cost. Tomosynthesis, again, compared to standard digital mammography. So the standard digital mammography is here on the left side of your screen. This is the tomo view. So you can see how it looks a little grainier, but if you look right here, this is one tiny little spot that is hidden in the midst of this dense area. And so if you have multiple views to look at this tiny little spot, you can catch that on tomo that would be invisible on standard screening. Whole breast ultrasound is another tool for us. One of the recent laws that's gone into effect within the last 2 years is the radiology facilities are now required to notify women of their breast density. So the breast density oftentimes is listed as either a category, A, B, C, or D, or sometimes as a 1, 2, 3, 4. There's also some specific terms that we use, but really what you need to know is if you have sort of intermediate or high dense breasts, you need to consider further screening, especially if you have any other risk factors such as previous biopsies or family history. Whole breast screening ultrasound, or ABUS, is another option for this. ABUS is an automated breast ultrasound. What this does is it allows the computer basically to run the ultrasound probe. And so the entire breast is screened, and it's screened in a very systematic way. So that way this can be repeated from year to year. This is not technician dependent. So that way women who have high dense breasts or who have family history or who have other risks that they're worried about can have this whole breast ultrasound once a year as another opportunity for screening. Again, this is oftentimes helpful also for women who get frequently called back due to breast density, again, just as another tool to help prevent that problem. Again, this is not technician dependent, so it's very repeatable and reproducible from one year to the next. It can identify solid tissue versus cysts. So for some women who have multiple cysts and have problems with that, this can really be helpful. It's non-invasive and there's no radiation associated with this. So again, that's another benefit. MRI is kind of the gold standard in identification of breast cancer. The benefit of it is that it's incredibly sensitive. It picks up everything. The problem with it is the specificity. The specificity is an indicator of how likely is the finding to be something concerning. And so you see that that's only 60%. So that means roughly 40% of what an MRI picks up is noise, is background enhancement, is benign findings. So the problem with that is that when we do an MRI, it may lead to benign biopsies. But you can see from these pictures how clear those images are and how clearly it shows a isolated cancer in the midst of that dense breast tissue. So again, it's very helpful for young women. It's also very helpful for women with certain types of breast cancer for us to determine the extent of their disease. Again, this is oftentimes used for women who are at high risk, but not usually recommended for standard screening for the average woman because of the risks of benign biopsies. Again, at Highlands Ranch Hospital, we have every one of these modalities available. 3D mammography, we can do ultrasounds, biopsies, bone density. Our imaging staff is phenomenal, and we have a very robust program, and also have a lot of availability for walk-ins as well as for same day or next day appointments. So again, we encourage you to stop in, especially if you haven't had your mammography, if you've been nervous because of COVID. This month is a great time to get back in, get screened. That's the most effective tool that we have against breast cancer. I see this every single day that women can come in for their screening, and they're totally surprised. They had no risk factors, they had no issues, but the screening saves lives. So this is our team at the Breast Care Center. So again, Dr. Ling, our fabulous radiologist, along with all of our breast surgeons, our pathologists, and our medical and radiation oncologists. So we have a fantastic program, a lot of really just remarkably smart and caring women who are there to help you. A couple of quick things on surgery and treatment of breast cancer. One thing I always want to hammer home is the type of surgery does not change the indications for chemotherapy. One of our common misconceptions when women come to see me for their breast cancer treatment is that mastectomy is going to be the most effective option. The survival is exactly the same for lumpectomy and mastectomy. There is no advantage to doing big surgery for most women. Recent changes in surgery, again, almost all surgeries are now outpatient. Our margins on lumpectomy are now smaller, so fewer women need to come back for re-excisions, which was a common problem. Women over the age of 70 can now oftentimes avoid lymph node sampling. We've have good data that supports basically not needing to do this for a lot of women. Many types of reconstruction are also available and can be done at the same time during the same procedure as the mastectomy, or even sometimes the lumpectomy. So we can do lumpectomy along with a reduction type procedure. We have fantastic cosmetic results these days. Again, most of our patients can hardly tell that we've been there, which is the goal. Recent advances in medical therapy, the biggest change and probably the most important change in breast cancer treatment has been the identification of the HER2/neu protein. This protein is found in about 20 to 30% of breast cancers and can be targeted by these two medications called Herceptin and Perjeta. These medications have really saved a tremendous number of lives in the last 20 years. These specific drugs target just the HER2/neu positive cancers, so they're not useful for a large percentage of the cancers, but these HER2/neu positive cancers were sometimes the most deadly. And now when we see this, we're actually somewhat happy to have HER2/neu positivity because it gives us more options. Immunotherapy has been in the news a lot, and a lot of people are really interested in it. This is used mostly for advanced or very aggressive disease. And so it's not always ready for prime time, although there are some new protocols becoming available hopefully soon that allow at least one immunotherapy agent to be used up front. And finally, genomic testing. These tests are looking at the genetics of the cancer itself. And what this allows us to do is to predict the likelihood of the cancer coming back elsewhere in the body in the future. We use this as a way to guide the decisions about chemotherapy. What this has done really is made it possible for a lot of women to avoid chemotherapy that would have previously needed it. So these tests are really helping to reduce the morbidity and the difficulty of getting through chemotherapy and cancer treatment. Radiation is also making changes. Again, we've got lots of shorter courses for lumpectomy treatments. We've got basically reduction or not needing to do radiation at all in women with DCIS at times. Again, each one of these options are tailored for the individual patient and for the individual cancer. So there's not always a one size fits all, but certainly we are working towards reducing the amount of procedures that we're doing, reducing the amount of treatment that patients need, and really trying to tailor each woman's therapy. The radiation also has become much better as far as the technology is concerned. Our Superman beam from the 1950s is no longer a thing. So there's no radiation going straight through you and damaging your lungs and your heart anymore. Our CT scanners and our 3D imaging allow us to really tailor the radiation just to the breast tissue and to prevent doses of radiation to other organs. So in summary, from my standpoint, we've got some really great options for screening, and I encourage you, if you have not gotten your screening or if you have a loved one who needs their screening, please encourage them to reach out to us, reach out to anybody, get in, get your mammogram done. Really, we have great treatments, and so the biology and the patient guide the therapy, and this is a very shared decision-making process with the providers. We spend most of our time educating and coordinating with the patient. We are not here to tell the patient what to do. We are here to help the patients make the right decisions for them. And so I encourage you all to stay informed and get your screenings. Thank you.
I'm going to share my video just to keep myself grounded and oriented. Thanks, Dr. Widner. I learned some things, even though I learn from you most weeks lately. I'm Kristina Markey. I'm a genetic counselor and I work at the Cancer Center at the Highlands Ranch in the CU specialty care. I've worked in cancer genetics for about 20 years. And I work with families who deal with cancer. And then so I see lots of unaffected individuals, but who are concerned about their family history of cancer. And then also I work with affected individuals. And while breast cancer is definitely a large section of the patients who I see, I get referrals for all kinds of cancer diagnoses and try to help in evaluating whether gene testing could be useful for that. I need to do what Dr. Widner did at first and find how to forward the slides. Here we go. So today I just want to acknowledge that while we're talking a bit about genetic testing, I know that it's probably not relevant for most people. What I do is try to determine who could benefit from genetic testing. That's part of my role. So I kind of want to throw in some additional perspective if this isn't your main concern today and it's just a curiosity. So an overview, I do want to just talk a bit about cancer being common. It's not an unusual problem for human beings to have. And often I'm able to be reassuring for some of my patients because of that. Cancer is kind of normal when we get to be 60, 70, 80 years old. We have a hard time accepting that, but our bodies really just weren't designed to prevent cancer for the long lives that we're living now. I want to focus on some of the red flags about things to look for regarding hereditary cancer, and a bit about the genetic counseling and testing process. But part of that is knowing your family history. So I want to stress how important it is to meddle a little bit with your relatives and ask questions, because even outside of cancer, having accurate medical history about your close family members in particular can be useful for your primary care doctor and other clinicians too, for other health concerns. Gene testing, when we talk about that more specifically, has pros and cons. There can be drawbacks from certain patient perspectives. So I'll briefly mention those, and then also the benefits of it. And if we have time, I'll just spend a little time on reminders about healthy lifestyle to help reduce risk for all cancers. Some of that is actually on this slide. This is from a website called the Colorado Cancer Coalition. This is actually a recent, I swiped this last week from their website. The data in the middle looks a little outdated, but this is just SEER data and it comes in long intervals like this. What I want to point out is where the blue arrow is. The common cancers in people, because anyone can get cancer. And I feel like I meet certain individuals who don't realize that. And that's what I want everyone to realize. Anyone can get most any kind of cancer. Our chances depend upon a lot of things, but people need to pay attention to their bodies and realize even if there's no family history of breast cancer, it is the most common cancer diagnosis in women, and 1 in 8 women will get breast cancer. That's a statistic many of us have heard before. Most of them don't have family history. Same with prostate cancer, 1 in 7 men. So you can see these other cancer types that are most common in Colorado: lung cancer, colon cancer, melanoma, common in both men and women. Women also deal with uterine cancer fairly commonly, postmenopausally in particular, and men with bladder cancer. And if you look down at the bottom left of this slide, 5 ways to reduce your cancer risk, I'm going to just highlight the things we can do to reduce risk. And that includes reducing smoking, eliminating smoking, avoiding secondhand smoke, being active, eating healthy, which in the cancer realm does mean lots of fruits and veggies, and keeping a healthy body weight as much as possible. And then, of course, screening, because early detection is huge for how what the options are for treatment and success for treatment. So we have general population screening for cancers, like Dr. Widner was discussing for breast cancer, but we've got colon cancer screening, prostate cancer screening, lung cancer screening from former smokers. So these are things that most PCPs are really good at helping average risk people access. And again, knowing family history is really important here. This is something I use a lot when I'm meeting with patients. Somebody's individual cancer risk really depends on lots of things, and some of them are in my imagination. So the biggest risk factor for cancer is being human. And the second biggest risk factor, which feels uncomfortable, is chance, at least from how I understand things. It seems like there is so much chance with who gets cancer and who doesn't. And sometimes that's helpful for people who I work with to hear that there wasn't something in particular that we know they did or didn't do, you know. There are really very few lifestyle or environmental risk factors that we can point to and make a good guess that that contributed in some way. One is lung cancer. Another would be, you know, skin related cancers because of sun exposure. But beyond that, it's often quite hard to pin something on a certain thing. Maybe asbestos and lung cancer too. So aging, the longer our bodies are here and having these influences that impact our DNA code in different cells in our bodies, the higher the chance is that just the right combination of gene problems will come together in a certain cell in our body. So aging is a big risk factor. And like I said, it's common, and I don't worry too much if I hear about a family member of somebody who I'm meeting with who had a cancer, really most kinds, at age 80 or age 90, even in the 70s. It's most likely just aging and chance. When I see a cluster of certain cancers in a family, so let's say I have a patient who's unaffected, but she's got a mom, an aunt, a grandma with breast cancer, or 3 close relatives with prostate or colon cancer, all the same kind of cancer. When we see family history of the same kind of cancer, it's interesting, and it's easy to jump to genetics as an explanation, but families often share lifestyle habits that could be risk factors for the cancer type. They also grow up in the same house, the same town. So if there happened to be some important exposure or subtle environmental influence on something, they may all have had that happen to their bodies without being able to know it. So when I think of cancer, it's really about all of these things. The genetic piece is, I think of it in a couple ways. There are small genetic risk factors that current genetic testing is not good at identifying. And then there are moderate and large genetic risk factors in the area of breast cancer, in the area of colon cancer, and other cancer types. We've identified single gene abnormalities that can track in a family and kind of clearly in a lineage often show us that there's an increased risk for cancer. So what I work with in genetic testing is evaluating for these moderate and high risk genetic abnormalities that are in single genes. When people have genetic testing and it's normal, I cannot tell them for sure that they don't have any genetic risk factor, because there are small genetic risk factors, and many of them that this kind of testing that we do doesn't identify. We're working on that technology, and I imagine especially in breast cancer and prostate cancer in the coming 3-ish years, we might be ready for rolling that out to the general population. Right now it's kind of research-based. I'm going to skip this and just to help you see how common hereditary cancer is. So the moderate and large genetic risk factors that are caused by one gene out of our 20,000 genes. It's the teeniest wedge here. So most cancers, it's 5 to 10% of those cancer cases are caused by a gene abnormality that gave that person a higher chance of getting that cancer. Most cancer is sporadic, just chance, aging, nothing they did or didn't do, no genetics. I don't have a test. If I could make a test and retire early, it would be a test to see who has sporadic cancer because it's hard to tell that. And so that's the tricky part of what we do in genetics with cancer. The green wedge of this represents what we call familial cancer. So this is a common thing we talk about in breast cancer in particular. We might see multiple individuals with a cancer, a breast cancer in a family, but maybe it's at older ages and it's just a little clustering, and genetic testing would typically be normal in one of these or all of these affected individuals. But because of what I said earlier, the small genetic risk factors that we can't test for, and shared environment and shared lifestyle, we know that family members of these people still need to be more cautious, not as cautious as somebody with a gene abnormality that causes a big risk, but more cautious than somebody who has no family history of that cancer. I'm going to skip ahead a little bit here to show you some features of inherited cancer or hereditary cancer. So these are the single gene abnormalities. So what I do when I work with a patient is help them collect a family history. And I'm hoping for accurate cancer diagnoses. That's a really important place to start. We draw a family tree. Men are squares, women are circles. The line here through this blue and female means that she's deceased. These three females have had breast cancer, and you can see their diagnosis ages here. So this is inherited cancer, and one of the hallmarks is young age at diagnosis. People have a genetic risk factor, and it doesn't take as long to have the gene mutations accumulate to cause a given cancer relating to that susceptibility. What we're also seeing here is that so this is showing a woman who I might meet with who's 43 years old, and her sister had a breast cancer at 45. Her mom had a breast cancer and died at a young age. Her grandma died at a young age of breast cancer too. And then on her mom's side of the family, we have two uncles who had serious prostate cancer. So this is showing that we're seeing this cluster of breast cancer, and then something that I know is that aggressive prostate cancer sometimes shows up in these families. So I can see it's all on one side of the family, and that is a big clue with inherited cancer. Sometimes the clue of the types of cancer will give us an idea about what genes we're most suspicious to find a problem in. Each gene has a unique personality. Somebody who gets more than one cancer in their lifetime, it can happen and not be hereditary. I feel like I work with that quite often. However, bilateral breast cancer is a reason for me to think twice about whether they meet criteria for gene testing. People who get more than one type of cancer, breast cancer, then colon cancer, breast cancer, then ovarian cancer, for instance, that can be a red flag. Certain rare cancers also can give us a clue that there could be something hereditary present. Ancestry and ethnic background in breast cancer is most important. What's most important is Ashkenazi Jewish ancestry. We know that 1 in 40 people who has both sets of grandparents as Ashkenazi Jewish ancestry 1 in 40 approximately will have a mutation in either the gene BRCA1 or BRCA2. So in a woman who has Ashkenazi Jewish background with breast cancer, we have a much lower threshold to talk about gene testing with them, even if they're 80 at diagnosis. The other types of cancer, when I said rare cancers, these are the other ones, and I'm putting them here because these things might be in your family history. So I've talked about some of them. Male breast cancer is important. Triple negative breast cancer. So that is a breast cancer that has is negative for estrogen and progesterone receptors. And then Dr. Widner was talking about HER2/neu, also negative for that. And so this type, probably about 15% of women with this type of breast cancer, which is a less common type, will have a gene finding on gene testing. And the most common one is called BRCA1. And I'll circle back to that in a minute. So I won't go over all of these, but ovarian cancer at any age, pancreatic cancer at any age, aggressive prostate cancer at any age. These are all important, and I can usually talk insurance into paying for gene testing if this is in a close relative or in a patient. So the reason that family history is so important is I do a lot with age at diagnosis. Whether someone gets their genetic testing covered by insurance depends on that. So if somebody is vague and just guessing about age, that can be a problem. Young age is really important, and getting clear on that is valuable. The other thing is, I'll just bring up, in the setting of breast cancer, sometimes people will tell me their aunt had some kind of female cancer. And that happens a lot. People, especially in older generations, they didn't even say cancer, and they definitely didn't talk about the individual body parts. But there are extremely huge differences in hereditary cancer concern to depending on whether a female cancer is cervical cancer, almost never hereditary, or ovarian cancer. 1 in 5 women with ovarian cancer have a gene problem. So even though it can sometimes be uncomfortable, it's worth asking for details. And, you know, all families are a little different, but that's part of what I help people navigate with what I do. Both sides of the family are important. We can inherit a breast cancer susceptibility gene just as easily from our dad as we can our mom, and all the cancer susceptibility genes come that way. So dad's side of the family is important. 3 generations of history when possible, accurate diagnosis, age at diagnosis. And then I always think, how big is the family? Doctors always often have interest in who had cancer, but I like to also know, is this a big family or a small family? Because that shows us how concerned we need to be. So everyone has a risk for any kind of cancer, kind of a general population risk. This graph is kind of what I think about when I'm working with a person. As a genetic counseling visit, at the genetic counseling visit, we take a bit of a medical history about cancer and tumors mainly, but some other things as well. And then obviously family history. And then we talk about if gene testing is indicated, but these are the things that help us in our cancer risk assessment. So we all start with this average risk. So breast cancer, average risk, 12% over our lifetime. If we hear that our patient has a mom with breast cancer or a sister with breast cancer, we wonder, did she have gene testing? If a gene abnormality is identified in a mom or a sister, then we've got an easy test to evaluate the patient's risk. And so the patient, if a family member has a BRCA1 mutation, let's say, that's a high risk breast cancer gene. So her breast cancer risk just shot right up to the highest that we think about. And that risk is about 50 to 60% in most families for breast cancer. Some families, it seems a bit higher. And our earliest data told us 85% chance in a lifetime. So the families that helped us identify these gene problems, the cancer risks were quite high for breast cancer. There are moderate risk genes for breast cancer, so the risk is more like 20 to 40%. And then the risk models that Dr. Widner was talking about help us identify and kind of quantify familial risk. So those people who have normal gene testing in the affected individuals, but because of small genetic risk factors that this testing doesn't detect, we need to be more cautious than general population. And that helps us figure out our screening recommendations. I want to just talk a little bit about why this is important. And I'm going to skip through some things here that I have just in case there are questions, but I'm going to skip this for now just so I don't get to spending too much time on it. In the breast cancer setting, many people have heard about the genes BRCA1 and BRCA2. Those are the most common genes that are the high risk susceptibility genes. Probably 1 in 350 people has a mutation in one or the other of those genes. They were the first that we found. We used to only test for those. Now, though, we test for a whole panel of genes at once, and I help people decide about that. And so anyways, we work with these gene panels. There are high risk breast cancer susceptibility genes and then the moderate risk ones. And that, depending on which gene we find a problem in, will help us guide screening. So for all of those people and people with familial risk, we talk about high-risk breast screening, which Dr. Widner discussed, and starting 10 years before the youngest diagnosis in the family. Some families with, well, all people with high-risk susceptibility breast cancer genes, we generally will have some discussion about risk reduction through medicine, like tamoxifen or an aromatase inhibitor. It can help reduce risk for certain types of breast cancer. And then there's prophylactic surgery. So prophylactic means kind of preventative. And some women who hear they have a 50 or 60% risk for breast cancer will want to learn about this option, especially if they're young when they find out. And they might meet with some of our providers, Dr. Widner and then plastics team, to learn about what that process would be like, what the surgery and recovery is like, what reconstruction options would be useful for them to know about. And some women might elect risk-reducing surgery to make their breast cancer risk lower. And that does reduce the risk of breast cancer pretty significantly. If we're dealing with a different kind of hereditary cancer syndrome like colon cancer, we've got similar strategies. So chemoprevention sometimes includes taking a certain dosage of aspirin to reduce risk for colon cancer. That's some new data that's come out recently. Also prophylactic surgery in some instances with some of our colon cancer syndromes. So that's kind of how we think through how the gene testing can be useful. It significantly changes our screening recommendations from just that idea of familial. It also helps us identify other family members who are at risk. I'm going to kind of go fast on this, but brothers and sisters have a 50% chance of sharing that genetic risk factor if it's one of these high and moderate risk single gene abnormalities. Brothers and sisters have a 50% risk of having it, a 50% risk of not having it. And then other relatives, it depends what side of the family it came from. So I spend a lot of time trying to educate people about risk to family members. And that's another layer about the complexity with what I work with. So one concern about gene testing in this area is that this is a piece of health risk information. So if someone's dealing with a cancer diagnosis, sometimes it feels good to hear there's a reason and we know what it is. If someone's not dealing with cancer and they're dealing with a percentage likelihood of getting a cancer, some brains just find that hard to manage. And so my main concern is that gene testing results can create anxiety for people that's difficult to manage. I think it's normal to be anxious when you first hear of something like this, but most of our patients really, once they meet with us, understand it better, meet people who can help guide them like Dr. Widner, feel better over time. And once they start their management plan, they do real well. There are a few people who need more support than that. So that's a consideration. Other people are concerned about privacy. That comes up quite a lot lately with just internet concerns in general and data management and risk of data being breached. Also discrimination concerns in the insurance industry. And that's something that I get into with anyone thinking about gene testing. But in general, we are well protected against health insurance discrimination in this country now because of a law that was passed in 2008. And it's more in those other insurances that this can be a concern, like getting life insurance. If you've had a gene test showing you have a higher risk for cancer, but you're healthy otherwise, it might be harder to get a policy, or maybe it's a little more expensive. So I'll skip the details of that for now because of time, and just kind of jump forward to talking about those lifestyle risk factors with cancer. So this is important for everybody, including people with gene mutations that this testing can identify. But for everybody, look at this. Lung cancer and other cancers happen with smoking as a risk factor. And using the Colorado data, smoking seems to be, actually, this is from American Cancer Society. It is a factor in 3 out of 10 cancer deaths. So lung cancer is one of them. Bladder cancer is another one of them. Smoking is a risk factor in cancers that are surprising cancer types. And you can learn more about that at cancer.org. Healthy weight. So, you know, we all go through ups and downs through our life, but look at this, the next 3, healthy weight, just moving our bodies more and eating enough fruits and veggies and limiting alcohol consumption. So all kind of like diet and exercise. 2 out of 10 cancer deaths are related to that. So these are the controllables. We can't control our genes. We can control some of these things. The last thing, just in Colorado, especially skin protection, because skin cancer really is one of the more common things in older people. Most people do well with treatment and recover and so forth, but protecting our skin is also a good idea. I'm going to stop there and we can spend some time on questions.
Hi, everybody. You can see me now.
We can. Yeah, thank you, everyone. So yeah, now it's time to do some questions. Thank you to our presenters. So if you could just type the questions you have in the Q&A chat box or in the chat, we will answer those for you.
While we're waiting for any questions, just one more plug. So if you have a loved one, a family member, a daughter, sister, cousin, mother, wife, bother them about getting their breast exam and their mammogram this month. This is kind of what we do, and I can tell you every single day I see somebody's life saved because they got their mammogram. So please don't be afraid of that. The COVID precautions are really strong right now. Everybody's really working hard to make it safe to be in the facilities to get those testing done. So please don't hesitate.
All right, looks like we have a question here. The question is, if you have a parent who smoked and developed bladder cancer, does that increase your chance of developing cancer?
Oh, that's a good question. So this is an example of how environmental exposures can be tricky. But when I first hear that, if it was an older individual who got bladder cancer at an older age, and there aren't other reasons in their family history for me to think more about it, like if it's the only person with a cancer, then, you know, if that could likely be a sporadic situation where the related genetic risk factors to family members are low or maybe zero, although again, we can't ever say that. But sometimes we'll see things in family histories. I'm thinking of Lynch syndrome, which is a common colon and uterine cancer syndrome. We can sometimes see other types of cancers that are urinary tract type cancers. So, you know, it's kind of with full picture, but I do always think it's important to report the family history to your PCP. So, because they kind of stay pretty up to date on some of this as well. So whenever it's a first degree relative in particular, just let them know, even if we think it might be related to a certain risk factor that we can pinpoint. Bladder cancer isn't one of the ones that I think too much about with hereditary cancer.
Thank you, Christina. We have another question in. Any guidance on screening after prophylactic surgeries for BCRA1+ for women?
Yeah, I'll take that one. So if you've had prophylactic procedure for BRCA mutation, your risk for developing breast cancer is incredibly low, somewhere around the 2% range over your lifetime. So you really don't need to have screening. There are no current recommendations for screening. However, you know, certainly I do encourage women to just, like I said, be aware, be conscious of your breasts. And I have unfortunately seen cancer in that setting. So it can happen, but it was picked up on physical exam by a conscientious physician, and the patient, you know, has done very well. But, you know, it's unlikely. And so there's no current recommendation for screening, but do get a yearly breast exam.
Great, thank you. And another question we have, what do you know about the PALB2 gene? My sister is currently being treated for triple neg and has the PLB2 gene. She is 60.
Okay, thanks. So I actually have a slide. Are you able, Hannah, to go to slide 16? Well, it was my slide 16. It is, well, there's a chart with different, this one, forward one. Oh, I have the driver too. Yep, thank you. So this is these are the most common genes we find problems in when we do testing in people for the purpose of breast cancer risk assessment. The last one is PALB2, and these are listed actually in order of how common they are in the population. And then I kind of put my own bend on it, how common they are in my clinic. So it's last in terms of these 5 genes in commonality, but we see it fairly often in clinic. And you'll notice that the other kinds of cancers that can go along besides breast cancer include, we think, a important risk for pancreatic cancer, but it's hard to measure specifically what the lifetime risk is. Ovarian cancer, again, may be a risk, but slightly increased over the general population. But we can see more aggressive prostate cancer in men. I believe we have seen occasional male breast cancer with PALB2, and the odds ratio for developing breast cancer is about 3 to 4 times that of the general population. So that translates into, you know, a 40-ish% lifetime risk. Some families, it seems to be a little bit higher. And so it depends who this person is. Hannah, does it say who the relative is who has this?
No, it doesn't say.
Okay, so if it's a first degree relative, like a mom, a sibling, or a child, the chance is 50%. If it's a second degree relative, like an aunt or a grandparent, it's about 25%, just based on the odds of it being passed along. And so there's a great test, and providing that, providing that to a genetic counselor, the test result from the family member can help you just explore what it might be like to get that testing done for you or another family member, and explore the things to think about before testing. You can meet with someone like me and think about it. You don't have to do the testing just because you come talk to us. So, it's worth a chat, and you've got a great test in your family. You've kind of got a yes or no answer in your family about whether you have this risk factor or whether you don't. Many families don't have a test like that to tell them more about their risk.
She got back and it's her sister.
Okay, so that would be a 50% risk if you share the same parents. And, I just turning it around, these breast cancer risks, you have to flip them around as well. So many people, even people with BRCA1 and 2, those are the high risk susceptibility genes, people don't always develop a related cancer. So that's the tricky part. We can't figure out who will and who won't, or when, and so forth.
Great, thank you, Christina. And another question we have is, I had two genetic tests. One showed RAD50 and one showed RAD51. I'm thinking they are not the same with the different numbers, but both were not on the results. Only one on each test. I know the RAD50 has something to do with colon cancer. Why would gene testing show RAD50 and others show RAD51? I know my dad has colon cancer.
Okay, that's a good question. So genes, we can test for these genes in panels, and it really depends on you and your provider, what panel you order. There are panels that are as big as 84 genes, and I do those for my really curious, research interested patients if they talk me into it. But we don't know a lot about those, about half of those genes. RAD50, I would say, is one of those genes that we don't understand too well yet. And I certainly don't think of it as a clear colon cancer susceptibility gene. RAD51, there's RAD51C and there's RAD51D. Both of those are risk factors for ovarian cancer. That's the primary concern for cancer, with a gene mutation, an actual pathogenic variant in one of those genes. So the risk for ovarian cancer with those genes is on the order of 8%, I believe, over a lifetime. So still low, but we still like people with that gene mutation to have their ovaries taken out for prevention if they've completed childbearing, and definitely postmenopausally. That's one of the areas where we have fairly strong feelings about those guidances and recommendations, because ovarian cancer is a hard one to detect at early stages. And we're still learning about RAD51C and RAD51D as to whether it goes along with other cancer types too. Back to RAD50, it's not in a lot of the gene panels that I use, because I use more focused panels sometimes. And it used to be a gene of interest with breast cancer, and it kind of fell off because we didn't show that proved to be a real risk factor. So we're still learning about these genes, but I think your questions are important. And me or somebody like me would be happy to sit down and explain your test report to you. If you didn't meet with a genetic counselor in the beginning, you can just take that to somebody like me and discuss it, because we want people to understand what it means, and it is confusing.
And if your father had had colon cancer, your screening would increase regardless of your genetics. So that's important also to discuss with your doctor to make sure that you're starting your colon screening at an appropriate age. Again, that 10 years younger than your youngest relative. So just be aware that even if your genetics was negative, you would still need to do that colon screening at an earlier age.
Mm-hmm. And actually newest guidelines suggest even if your father was, say, 75 at diagnosis, you'd start at 40 and just be sure, and then get one every 5 years. That's a recent change from the NCCN guidelines.
Great, thank you both. And our next question is, when a parent has cancer, does it affect both sexes of children equally in risk?
I think it just depends on a lot of things. So female breast cancer in a parent is of more concern to a female child than a male child. A BRCA mutation or a CHEK2 mutation or PALB2 mutation in a mother with breast cancer, the breast cancer risk is different based on whether the child is male or female. It's much, 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 much lower in males, but it can happen. But the genetic chance of having that PALB2 mutation or whatever that risk factor is that led to this is important for both genders because of the other cancer risks that can go along with it. And if a person, including a male, has that genetic risk factor and their cancer risk is low because they're male and it's mainly a breast cancer concern, let's say, they can still transmit it to their offspring with that 50% chance. And then if they had a daughter, she could have that more heightened concern for cancer because she's female. Did that seem clear?
Yes. The cancer risk may change, but the genetic risk is equal.
Yeah.
All right, we have another question in. Do dense breasts indicate higher risk for breast cancer, especially considering my mother had early onset breast cancer?
So yes, the breast density in and of itself is not necessarily an increased risk for breast cancer so much as an increased risk of being difficult to identify the cancer. And that's where that recommendation now came from the state a couple of years ago that we have to notify women of their breast density. And so a lot of women think they have dense breasts, but on mammography, again, you'll get this category A, B, C, or D, or if you're told that you have either heterogeneously dense or extremely dense breasts on mammography, those are women that should get additional screening. Again, either with whole breast screening ultrasound, MRI. Again, if your mother had breast cancer, you would likely qualify for MRI screening. And certainly if she had diagnosis at a young age, you would most likely qualify for genetics as well.
Mm-hmm.
All right, great, thank you. It looks like we've covered all of our questions here. I just want to thank UC Health again for giving us the opportunity to learn more about genetics and the risk of breast cancer. And thank you, Kristina Markey and Dr. Jodi Widner. We really appreciate your time. And thank you to all those who joined this evening to learn more about the risks.
Thank you, everybody.
Yeah, thank you.